Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Hi, I'm Keanne Armstrong, your host for Being Well. Thank you so much for joining us today. Today's topic is about women's health, physical therapy, the problem solvers for gynecologists, obstetricians, and urologists. And today joining me is Dr. Millie Nelson, an OBGYN with Effingham Obstetrics and Gynecology. And I also have Leah Passalacqua, a pelvic floor physical therapist with HSHS St. Anthony's in Effingham. So thank you so much for joining me today on this episode.
Thank you.
You're welcome. So we've got a lot to talk about. A lot is coming into play with pelvic floor, physical therapy, women's health. So is this something new? Is this something that's been around for a while? Where would you like to start to talk about this discussion?
So the field of women's health physical therapy emerged in approximately 1995. And so it's a relatively new field of physical therapy. Leah has specialized in pelvic floor physical therapy and done additional training to develop that expertise. As we've learned through time that her skills can be applied to help a myriad of gynecologic and obstetrical conditions.
Okay.
There's been a lot of new research in recent years as well, and so it's a constant learning process, and there's more that we can utilize to help our patients, and it's continuing to grow and grow. So it's a great field for progressive treatments and really lots of help for our patients.
So it offers a non-surgical, non-invasive, successful opportunity or adjunct to some of the traditional things that we've done in the past.
So this has been around for a little bit, but it's fairly new. 1995 isn't that far away. So let's talk about some of these newfound methods so we can get this information out to some women who may be struggling with this, that maybe don't want to talk about it, and they need to know what options are out there.
So I'll start with the different categories. So in the field of obstetrics,
yes,
maybe 70 to 80% of women during the course of their prenatal life will experience some musculoskeletal discomfort. They might complain of back pain in the lower area, sciatica, where the pain radiates down the back of their legs. They might complain of hip pain. And, you know, traditionally we as obstetricians have sort of like shrugged our shoulders and said, yep, that's part of pregnancy. Too bad.
Right, deal with it, it hurts, you just can get through it, right?
Right,
Yeah.
And so research has shown that serious injuries can occur to our joints during pregnancy, and that involving and incorporating physical therapy from the beginning of your prenatal course to delivery and potentially afterwards can be helpful. Okay. So I'll let you chat a little bit about some of the things.
Yeah, so you know, it's one of the things when someone comes in, we see lots of different diagnoses. Like Dr. Nelson said, it's everything from back pain to carpal tunnel type symptoms, and we look at their stability within those joints and where they're having pain, because of course with pregnancy ligament laxity comes into play as well. So one of the things that we do is go through an individualized assessment and see what is lacking and develop a home program as well as a program there to improve the stability around the joint or the area of pain.
There's a hormone secreted in pregnancy called relaxin, and it relaxes all joints. So it relaxes the connections between bones. So those ligaments relax and and stretch, and it's like a pulled muscle, right? You feel that, and it's uncomfortable.
Yeah.
So when you're like 9 months pregnant and you push on your pubic bone and you're exquisitely tender, it's often because your pubic bone has separated for ultimately to allow the baby to come through the birth canal. But there are things that Leah can do to alleviate some of that discomfort.
During the pregnancy.
During the pregnancy.
Okay. Why don't you talk about that a little bit?
So sometimes one of the things that we like to do is do a generalized muscle assessment when someone first comes to us, and not just in the area of pain, but in any area that may affect that area, which is basically your whole body, because we are a whole person.
Right.
So we like to look at everything and then look at what we need to improve the stability around that area or to give them the pain relief that they need. And it varies with every individual as far as what we would come up with for a plan to help them.
Well, yeah, because everybody's body's different. Every pregnancy is different. So
Absolutely.
we're talking about different things that you can do to help women through the pregnancy phase. Does it change throughout the course of the pregnancy, what you can help women with, and maybe where the pain is coming from or the discomfort?
Well, some of the excruciating discomforts come after the delivery or through the delivery process. So imagine you're pushing and I'm flexing your hips up to your knees to open your pelvis to get that 9-pound baby out. Well, I can create a nerve entrapment syndrome, and you could have the baby and be really happy and barely be able to walk the next day.
No, that's not good. No.
And then the second thing is that, about 50 to 80% of patients, when they have a baby, will experience some tearing in their the vagina and the space between the vagina and our anus, which is called the perineum.
Okay.
That can increase our risk of having pelvic prolapse problems later on in life.
All right, let's talk about what pelvic prolapse actually is. We hear that term a lot, but what is it exactly?
So it's not one of those things we generally go out to lunch and talk to our girlfriends about. But a common initial complaint of a patient who's just trying to start a conversation will say, "I feel pressure down there. I feel like my cervix is rubbing on my underwear. I feel that when I go to have a bowel movement, it doesn't come out the same way. It's pooching through my vagina, essentially. I have bladder control problems." Approximately 1 in 10 women having a baby today will also experience damage to the sphincter that controls our pooping, our rectal sphincter. And that can have long-term consequences. And if you don't have the problem, you can't imagine this, but imagine you go to do your little morning bowel movement and you go get dressed and you go to the bathroom in the middle of the day to urinate, and you're like, well, why are my underwear soiled? Well, some of that sphincter isn't tight, and so some of that stool has left out. You don't tell your girlfriend about that.
No.
Right?
Well, people are very shy about these types of things because it's embarrassing. You don't.
3/4 of women after having a child will note that they have some back pain issues. And a lot of times we like to blame it on their epidural, but it may be from the size of the baby, pushing on the pelvis, the pushing, the birthing process, and the pulling and stretching of the lumbosacral lower back area.
So how does the physical therapy play into some of these types of things that you're talking about with the prolapse and the tearing and the back pain?
Well, so before you start talking, it is now being suggested by the American College of OBGYN that I should incorporate routine discussions of pelvic floor physical therapy for prenatal care of all women, and that it should be a routine discussion at their 36-week visit with the offer of a routine physical therapy consultation after delivery.
Oh, okay.
So, instead of you just coming in and saying, "Oh yeah, my back hurts," and me going, "Oh yeah, you just had a baby," or, I lose my urine a little bit. "Oh yeah, that happens. You just got to wait till it gets better."
Yeah.
You actively have the patient evaluated by Leah, who then can develop a treatment program.
Right.
Right. And We're really trying to start early on. So when women start their prenatal classes, we're wanting to kind of get in there and educate them on this is what can happen during pregnancy, but this is what can happen after pregnancy, and address those issues. And one of the things when they come in post-delivery that we start with is just educating them on the pelvic floor. You know, it's comprised of 3 muscle layers, and women don't know this, and 20% of all vaginal deliveries result in a tear of the 3rd muscle layer, the levator ani muscle, and that can lead to prolapse down the road or incontinence as well. We talk to them about all of the connective tissue as well as the ligament support and the nerves in the area and what happens during that process, and then assess them because everyone is affected differently from a vaginal delivery or a C-section. And then moving on from there, then we decide what we need to do to best treat them to help to strengthen that area or get the muscles even back firing. Sometimes, you know, after nerves are stretched, then the muscle doesn't really want to respond. So how do we best get that muscle to respond to give them the stability that they need for not just their pelvic floor and continence, but also for their core stability and their overall pelvic stability. Some of them have difficulty walking, you know, post-delivery because of all of the ligament laxity as well. And it can be, they can also, sometimes they have a tear, it's called a diastasis recti, through where their abdominal muscles split. So we'll do strengthening for that as well to improve their stability. And they feel much better once they start getting stronger, and their pain decreases and their anxiety and concern decreases because it's scary. They don't know if this is normal or they don't know what to expect. So
Well, and I think something that would be normal to think is, am I going to have to live with this forever? Is this the way I'm going to feel?
Right.
So no, it doesn't sound like it. It sounds like there are options out there, non-surgical, the physical therapy route. So talk about some of the things that are actually done through the physical therapy. So should we pick maybe one topic to start with? Which one do you want to talk about? Like prolapse, which one?
Sure. I mean, there's a huge variety of different treatment methods that we use. Sometimes it's manual treatment methods, so with our hands. Sometimes we'll do external trigger point release on the muscles, as well as even internal trigger point release if they're having pelvic pain issues to try to release the tightness. Sometimes we'll use biofeedback, which is hooking electrodes up to the patient, and they seem to really respond well to this. They can look at a computer screen and actually see what their muscles are doing. So it tells them if their muscles are relaxing or if their muscles are contracting. It also tells them if they're using the wrong muscles, so they may be doing a Kegel incorrectly, and then we can say, okay, you're trying to use all of your accessory muscles instead of the correct muscles. This is why this muscle group isn't getting stronger. And then they develop better body awareness, and it helps them through that process. Sometimes we'll do pain relieving treatments, and it can be anything from heat or cold, manual stretching or positioning. Sometimes we'll look at their overall posture and then their pelvic symmetry as well. And sometimes they have some asymmetries that need addressed to give them some relief as well.
Okay. So Dr. Nelson, how do you know when is the right time to send them to Leah?
So if somebody comes to my office, so in the world of obstetrics, I am incorporating a discussion of these are the things you might encounter in the next 9 months, and that physical therapy is an option for you, or when the patient comes for back pain, or at the 36-week visit, I don't know what your delivery is going to be like till you go into labor, but in particular, if you have a more serious tear during the vaginal birth process, I would immediately incorporate a discussion of, well, why don't you go see physical therapy to see if we can't help you recuperate and get back to normal faster.
Yeah, so I think most women, consider myself most women, the way they think is that they would think, no, I have to have some sort of surgery, I need stitched up somehow. So no, there is this physical therapy.
The traditional time of a patient coming to see me with complaints of what turns out to be pelvic prolapse findings
Yes.
is generally somebody who is my age, somebody who's gone through menopause. So sometimes things that occur prenatally and during obstetrics will get better on their own to some extent. But once you go through menopause and lose vaginal estrogen and your tissues become thinner and less elastic, then they become more pronounced again. And you live your life. You work in a factory and you lift heavy boxes for 25 years, you know? And oftentimes it's when they're older that they express that concern. Whether it's I have incontinence problems, or I have urinary or fecal incontinence, or I feel my vagina or cervix or uterus coming out, when I talk about all the things that can be the cause and that I can offer to them as treatment options, I always encourage pelvic floor physical therapy. It's actually a component that should be considered not only in the evaluation of those patients, but let's say that patient subsequently chooses to do surgery. You want that surgery to work, and there is a failure rate to certain pelvic prolapse operations, especially for bladder prolapse.
Really?
But if you incorporate pelvic floor physical therapy in the postoperative recovery, just like an orthopedist would say, okay, you had shoulder surgery, you need to go to physical therapy to get your arm motion back, right? But we haven't traditionally thought about that. But if we incorporated that, then you would maximize their recuperation and maximize sustaining that.
Yeah.
And I will say, when I send a patient for pelvic floor physical therapy, they come back and they say to me, that was great. I learned so much about myself. So then they know what to do. So when they get those symptoms, oh yeah, this is what Leah taught me to do, and they go back to some of those exercises that they were taught.
So I guess some of the exercises you do in the facility, but then some are at home as well? Is that how it works?
Yes, so I give every patient a home exercise program, and upon discharge, I always make sure that they're doing them correctly, because we say this is something you're going to want to know for life. You know, should you start to notice any of these issues reoccur, you can start doing your exercises right away if you haven't continued them to try to alleviate the symptoms. But we also have a great collaboration with Dr. Nelson and our physicians, that if our patient isn't making the progress that we want them to, then we send them back and say, we're not getting the outcomes that we were hoping to achieve, and they may go on to need surgical intervention or a pessary or something along those lines.
Okay, so are there reasons why physical therapy may not work? I mean, is it just...
So if you're coming to see me and you've had your problem for 25 years and you've kind of ignored it.
Right, didn't want to talk about it.
Didn't want to talk about it. If I had to intervene when you had your child and your problem was, you know, level 1 or level 2, she would have been way more successful in producing a sustainable correction of your problem.
Right.
But if you're waiting until your cervix is hanging out of your vagina, unfortunately, no matter what Leah does, I've had some patients.
Right.
Leah said I'm just too far off.
Had you only come seeing us sooner.
Yeah.
Well, right, but I always say it is a win-win, because if they go on to have surgical intervention or something else done, they know how to maintain that strength, and they're going to have a more successful surgery and outcome.
Right, so either way, whether it's during the pregnancy, after a surgery, it's coming in handy and helpful for all of these women. So we've talked about the pregnancy route, and we've talked mostly about vaginal deliveries. What about the C-section, or even later on in life, a hysterectomy? I mean, does this play into that as well?
So I would offer pelvic floor physical therapy to all obstetrical patients, regardless of their route of delivery, because they, even a person with a planned C-section can have separation of their pubic symphysis, tears of the labrum of their hip bones, lumbosacral issues, you know, that can benefit from pelvic floor physical therapy and manipulations in those areas. So I don't know that it matters how their baby comes out. Certainly the vaginal route does place a little bit of an increased risk of tears of, as Leah talked about it, the complex of muscles called the levator ani. This has sort of led some people in the world to think that C-section as a primary mode of delivery is a preferred method of delivery. So this is not the forum for this discussion, but there's a lot of debate in our world today about what is a acceptable C-section rate.
Right.
You know, or are you Britney Spears who says I'm, you know, too posh to push, right? And I just want a primary C-section because my perineum vulva is too important for me.
Well, that's a debate for another time, right?
Yes, it is.
Yes, it is. But I guess the thing that we're talking about today is we need to be proactive. We need to learn about our bodies. And, you know, you said a few minutes ago, you explained, you know, the organs inside a woman's body to the women because we just don't know. We think we know our bodies, but a lot of times we just don't, do we?
Right, that's so true.
Yeah.
And you're right, they are when you empower them and give them the tools to help themselves, it decreases their anxiety and decreases the stress level towards the whole situation and enables them to just move forward and to achieve their goal.
So is this something that you go through an OBGYN to see you? Do you get a referral? Is that how it works? What's the process?
So if somebody, generally I think your patients are all referred to you, is that right?
Yes.
All right, so once they get to you then you have this plan that you sit down, you evaluate them, you go through everything. Are there tests or how do you really pinpoint this is what we need to do for that person?
There are specific evaluation tools that we go through, and we have kind of a sheet on our website what to expect when you get referred for pelvic floor physical therapy.
Okay.
Because a lot of women come in and they're like, I had no idea what to expect. My physician just told me to come here.
Right. This is something brand new. I've never heard of this before.
Right. So definitely we do specific testing. A lot of times we'll look at joints and then at symmetry and then at overall strength externally, but then we also, if it's okay with the patient, we'll do an internal assessment where we assess the 3 different muscle layers of the pelvic floor and then also hook them up to biofeedback so they can actually see what their muscles are doing or are not doing, and then we send the evaluation back to the referring physician so they're on board and know what we found as well. And then certainly at discharge we get back with the physician again and say this is where we left things and this is either what the home program is or what the plan is, or they need to come back and see you. So.
Okay. Is there an average maybe length of time that people can expect to have the physical therapy? I mean, is it for weeks, months, days?
Typically for this type of diagnosis, we see our patients once a week because we give them lots to do on their own at home. An average would be 6 visits. Typically most people start seeing some changes at 2 weeks, but sometimes it takes 6 to 12 weeks before they notice some benefits. So we sometimes spread out our visits to every other week, even if we need to towards the end to make sure they're still progressing and so we can see those changes.
Okay. So do you then do follow-up visits with them as well and annual visits as well to make sure everything's staying where it needs to be and the muscles are working properly?
Well, also because sometimes I do more than one thing for a problem.
Okay.
So if you have really significant stage 4 pelvic prolapse, I might say, let's have you see Leah for physical therapy, but at the same time, let's try putting a pessary in your vagina, which is a device to hold it up. You know, or if you have incontinence, there are lots of different things that can cause incontinence. And I might suggest you have a test in my office to evaluate all the various components that cause that. Leah will help with some components of the incontinence, but there are other modalities as well.
All right. Well, we've covered a lot of areas today. We have about 1 minute left. Is there anything that we need to wrap up?
Yeah,
I
want to make a plug for the use of physical therapy for pain with intercourse and for pelvic pain.
Okay.
These are 2 really common problems in women, and for what's called vaginismus, which is the involuntary contractions of those levator muscles that she was talking about. that prevent women sometimes from having intercourse. And it's very emotionally disturbing to them. It's emotionally disturbing to relationships. And she basically, I'm not
Changes a person's
exaggerating,
life.
she cures it.
Yeah.
She fixes it. The other thing is, we talk a lot about, women a lot of times, they have pain in their pelvis all the time. And they want to think it's their ovaries or something else. But it's really the interplay of the muscles and the joints. And physical therapy can be a very viable option for them.
All right, good to know. Lots of information being shared out there for women's health and about the discussion of the pelvic floor and physical therapy. Thank you so much for coming on today's show.
Thank you.
Thank you as well. And thank you so much for watching today. We hope it has been very informative for you. For more information, you can visit our website, weiu.net, and click on Being Well. We'll see you next time.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Carle combines clinical care, health insurance, and research in a way that solves problems today with an eye toward the future. Supported by a deep philanthropic spirit and dedicated to making life better for as many as possible.